And so we're going to be looking a little bit about educational interventions after brain injury, as these can look really different between children of all ages, all backgrounds. There's just so many factors to take into consideration. So we wanted to ask the question, what options are available and how can they be implemented in the school system, looking specifically about what impact brain injury might have on implementing these type of systems. So that's why we're thankful to have Dr. Joseph Bunch here today to talk about developing educational accommodations and interventions for children and adolescents with brain injury. Dr. Joseph Bunch has been a licensed school psychologist since 1980 with the additional traumatic brain injury provider credential since 2001. He has been licensed by the North Carolina Psychology Board as a health services provider psychological associate since 1992. During his career, Dr. Bunch has evaluated several thousand children from preschool through end of high school age, including many students who have experienced traumatic brain injury and a wide range of neurodevelopmental disorders. He concluded very early in his career that an evaluation is really only the very beginning of a process of providing ongoing specialized support to children with many potential needs across the school and familial settings. And so now we're going to launch his presentation, and I'm going to turn it over to him as soon as I get it up. Okay, excellent. All right, so I'm going to turn it over to you, Joe. Thank you so much, and I'm looking forward to learning more.
Well, thank you so much, Lauren, for having me in the Brain Injury Association of North Carolina, for doing these kind of webinars across a wide range of topics, as well as other kinds of important trainings related to brain injury for all ages of people. And I would like to move forward. You can go to the next slide. First, let me say that in an hour or so, it certainly is impossible to do a thorough training. So my goal basically is to introduce some ideas, to provide some hopefully additional information that you may or may not have encountered in the past, but to at the very least stimulate you to take make a greater effort to study some of these important issues on your own that are related to designing and implementing evidence-based accommodations and interventions for children across the developmental spectrum who have experienced some form of traumatic brain injury. So this is the broad outline that I'm hoping that we will be able to cover. I have included, I think for PowerPoint, a significant amount of information. I certainly will make an effort not to read too much from the PowerPoint, but it should serve, or my goal is for it to serve as a reference point for you in the future. Next, please. Lauren's changing slides for me, by the way. Let's begin quickly with a general definition of traumatic brain injury. I've listed the first bullet as the CDC definition, which is brief but significant. It is certainly well known that it's a leading cause of disability and death in children and teens. For those of you in North Carolina, which it appears to be most of us, and we also are thankful for anyone outside North Carolina joining us, but this is our Department of Public Instruction definition, and this is what I have to generally deal with when we have a school-related referral for a child who's already been diagnosed by a neurologist or a doctoral level neuropsychologist as having traumatic brain injury, or we get medical records that certainly allude to a traumatic brain injury, even if it doesn't come right out and say it. This is our current definition. And by the way, that definition was significantly expanded in 2014 to include injuries that are of an internal nature, like a brain lesion or other kinds of internal disease mechanisms that would cause an injury. Prior to that, our Department of Public Instruction definition was primarily focused on a brain injury that was acquired through some sort of external physical force, like a blow to the head or a penetrating injury, as the CDC definition would allude to. But we have found it, at least in my opinion, and in consultation with other school psychologists especially, we found this definition to be much more helpful and allows us to provide better services with more accurate definitions and considerations for children who are struggling and who have various kinds of injuries. Next. Now, in thinking about this, what would you consider some of the risk factors for a traumatic brain injury? Well, the literature suggests that contact sports, children and elderly people are more at risk. And interestingly enough, males between the ages of 15 and 30 are at more risk. And why would you think that? Well, sports related especially, but in this day and age, thank goodness, girls and women are playing sports and doing a lot of things that maybe 30 years ago they may not have been as encouraged to do. But the Women's Sports Federation and the wide and increasing level of participation in high school, college, and pro sports for females has substantially increased. And I would suspect that at some point that the risk level is not going to be so gender related. That's unfortunate on the one hand, but I think fortunate that everyone is participating in things that they may want to do or they're capable of doing. Next. Now, let's talk about prevalence. I certainly won't read this, but it's very clear that the prevalence of some form of traumatic brain injury in children and adolescents is high. So and my focus is especially upon what we do in the school setting to address the ongoing needs of children who have experienced a brain injury. So I'll focus a lot on during this presentation on what we do in the school setting. This emphasizes, just this slide related to prevalence, in my opinion, emphasizes the salience of having a clear understanding among educators and clinical providers that even go into schools to provide services, that they have a clear understanding of the prevalence of traumatic brain injury. It's certainly not something to ignore or to consider a secondary disability identification or anything like that. In fact, I would argue, based on my experience, and this is anecdotal, there's probably some literature that would support it. I think many of the children that we identify with specific learning disabilities and other disabilities likely have at least a mild brain injury in their history that has gone unreported or undetected. That's just a sense that I've had over many years. And my early interest in I really didn't think about traumatic brain injury at the time, but very, very early in my career, I was interested in the neuropsychology of learning disabilities. I just felt like that the kids who had the most significant learning disabilities were having some brain based issues. And over time, I've come to suspect, again, that at least in a minority of those kids, they're unreported, unsuspected brain injury. So it's essential for schools and school systems to be prepared to assist and to change some of their process, procedure, structure, etc. Next, Laura, thank you. And here, as you might have expected, are some of the primary causes of traumatic brain injury across the developmental spectrum. Next. Now, what would you say is the general impact of traumatic brain injury across developmental levels? Certainly, all these things are relevant at young ages, the middle of childhood ages, and teenager, and even into the early 20s. How these common problems emerge and manifest certainly may vary depending upon the age at which an injury occurs. But we will address some of these things as we move forward. Okay, next. Now, we are especially concerned about the cognitive and communication problems across the developmental spectrum. And as noticed in the previous slide, there are a wide range of concerns that emerge as a result of any level of injury. And I decided in putting this together not to focus upon mild, moderate, or severe injury. I have decided just to talk about brain injury in general. We could get into those sorts of things, but I don't think that's within the scope of this presentation. How these variables or problems might emerge could very well vary across mild, moderate, and severe symptoms. Next. Now, I do want to focus and really almost will read these. Cognitive impairments, as we see in children with brain injuries, do tend to improve slowly within the first 6 months to a year and a half, 18 months. And normally the greatest rate of improvements within 12 months. One of the struggles that teachers have, and others, parents as well, other kinds of providers, is that kids then will deny their issues because they're not readily apparent to children, and there's a notable lack of insight, especially in the early elementary years. The kids aren't really sufficiently aware just developmentally, and then the injury really interrupts any process of awareness they might have developed. Now, for older kids, teenagers, they may be well aware that they're injured, they're impaired in some way, but they're not going to necessarily be ready to discuss that or admit that. Kids that experience brain injuries are still, there's an overlay of the typical developmental stages. If you were to think of for teenagers especially, you think of Erickson's stages of psychosocial development. And there's a tension between being independent and acquiescing to whatever parents and teachers and others may say. Any kid, any teenager is likely struggling with that developmentally. But then when you lay the overlay of an injury complicates that. So not only do kids deny their cognitive issues sometimes because of lack of insight, it may be along the course of wanting to deny that anything's wrong with me, that I'm going to be okay no matter what. And also one of the things that seems to be most pervasive is when children and adolescents have brain injuries, they're gone away, they're away from school for a while. People know that something's gone wrong, but maybe it's a relatively mild injury, and others, maybe their peers especially, or maybe adults who don't know what has happened, they don't readily see an apparent injury. There's no bandage on, there's maybe the child doesn't have the gross motor coordination issues, etc. But they are experiencing notable difficulty processing information and reacting to their immediate environment. And if others don't perceive that and continue to react to them as if they should know what's going on, then that certainly can cause notable anxiety and frustration, which may lead to other kinds of emotional behavioral issues. Next. As we just alluded to, there can be emotional and behavioral changes that are directly related to an injury. Communication issues that occur as a result, even if they're mild from a receptive or an expressive perspective, certainly can cause notable frustration. If there has been some injury to the language areas, that again precipitates a wider range of difficulty with social interaction, which really results in some emotional reactivity at times. A child's, particularly early on, a child's capacity to think logically and rationally can be, particularly in the older children, be impaired, and that may take a good while to overcome. Even if it is overcome, it may not be as readily noticed in young children, because if a child is injured at the preschool or early elementary age level, the capacity to think through things, to problem solve, to develop or to have strong reasoning skills, those things are still developing. They actually don't stop developing until the early 20s. As we now know. So often injuries early in childhood significantly impact a child's capacity to think through things and problem solve. and there are other issues. There we go. Now, post-injury presentation, that's a critical issue. The developmental issues, during rapid developmental trajectories, which is essentially periods of rapid growth, the brain actually is much more vulnerable to a wide range of damage. That makes common sense, but it is well supported in the literature. The injuries that occur in early childhood, early elementary years certainly impact future learning to a significant degree. As we'll talk about a little bit later, the early skills in reading, math, and writing are certainly very impacted. And when assessed during any sort of informal or formal testing, kids in the early years will likely not do as well as they would have done pre-injury on reading, writing, and math. However, kids, middle school age kids or high school kids with mild injuries will likely score fairly close to what they would have scored in their earlier years pre-injury. Next. And here we have other factors that influence post-injury presentation. Now, I will highlight the bottom or the last item. Pre-morbid functioning is a strong predictor of post-injury functioning. I'm working with a student right now, a middle school student, who I have finished his evaluation, but he was identified prior to the 4th grade as having specific learning disabilities. And then in the 4th grade, the latter part of his 4th grade year, he was in a serious car wreck. And now he's in the 6th grade, and he's been in several school systems, and the current school system has decided that they want to investigate the potential impact of that traumatic brain injury, which was diagnosed from several years ago. What makes this both interesting and somewhat more complicated to assess from a quote unquote disability identification perspective is the question comes up: has the traumatic brain injury impacted his academic performance any more than his previously identified specific learning disability could have? And one could argue either way on that. I'm more concerned about the latent impact of the traumatic brain injury on his current and future functioning as his, particularly frontal cortex, the front of the brain begins developing with regard to reasoning, increased levels of attention, etc. His primary symptoms have been increasingly weaker capacity to pay attention and to organize things. So that's where we've been focusing our efforts. So looking at pre-morbid functioning is a really important thing for a lot of different reasons, and it becomes a little more complicated if children involved in an accident were already identified as having some learning difficulty to begin with. Next. Here are some of the social emotional problems generally that can emerge as a result of a brain injury, and I'm sure this is no great surprise to anyone. Next. The externalizing or more overt behavioral difficulties are here. I won't read through those. You can see those and probably imagine those. Now, certainly there's a wide range of potential impact upon learning, as a result of a brain injury. But the aspect of learning that seems to be most often affected and really pervasive across age levels, developmental levels, has to do with how does a child at any age organize, well, first, attend to their immediate environment and analyze, synthesize, organize the input they're receiving from their immediate environment. I mean, that's just a basic question for any child, much less a child has had any sort of injury. But when you consider how children over time develop an increasing capacity to understand, process, remember, organize, plan, and ultimately implement, whatever the task may be, and it may be something that is we not even at a conscious level, but then other things that are more planful consciously. Just the pattern of development, the teaching and learning that has to occur over time for people to be effective or functional, just from a typical or normal perspective. Think of how that is impacted by an injury. All the processes that we take for granted that we ordinarily do can be substantially impacted. They may all not be impacted, but as you see, all these things are interrelated. A prime example is visual perceptual processing and visual motor skills. It's not just visual skills or just perceptual skills, it's all of it. So if one aspect in this process of visual, perceptual, motor functioning is impacted, then the whole capacity for that process to be a fully integrated process is impacted. I mean, I think a straightforward analogy is if someone begins to lose their sight, their motor capacities begin to diminish, and all sorts of accommodations and adaptations, have to occur. With a brain injury, anywhere along the process could be interrupted. And I think that that scenario is analogous to any of these processes and aspects of learning. Because if you read through this list, they're all related in one way or another to learning. The way I often write it in a report is there's potential interference in the acquisition and maintenance of learning new information. We will particularly focus on executive functioning as we move through, which is related to problem solving, reasoning, etc. Let's go to the next slide. Okay, that I won't go through all of this, but there's always going to be an interaction between the educational issues and medical concerns. There are several important ideas here and variables here that we need to consider. Certainly, there is brain plasticity, which is a positive thing. It certainly underlies the capacity of individuals' brains to repair and to become rewired, so to speak, to function. However, there's no guarantee that everything's going to be repaired sufficiently and back to how it may have been, but at least we have that capacity of human beings. There is certainly going to be a potentially significant impact upon normal or typical development as a result of a traumatic brain injury, and certainly that varies across age levels. Another important issue is we cannot, as educators or providers or parents, quickly conclude that injury-related issues are going to resolve themselves over time. Because we can't necessarily, we're not a stage in the medical profession or any other profession to be able to make a clear prediction as to how complete a recovery process is going to be. So in order for the child, or I would say any age level person, but we're talking about children and adolescents now, in order for children to be patient with themselves, we have to be patient and supportive of them across an extended period of time. This is not a short-term commitment to facilitating social, emotional, behavioral change and relearning and learning. Is a continuous process. And if you take nothing away from this presentation, except that fact, then I'll be satisfied. Understand that, that you're in the long haul with every child that you're working with, or that you're parenting, or that you're supporting. The other thing to take into account is, from a very developmental perspective, especially with young children, is that the psychological, the neuropsychological impact of a brain injury can very well emerge over time. They're good, like I mentioned, the term latent, that means later. The later impacts of that injury 3 or 4 years ago, particularly if it's a young child, it's important to at least consider that things may not come up, weaknesses may not emerge until a child is challenged more academically or more socially at the age of, early adolescence. 9, 10, 11, 12, 13. There are things that would not be apparent at the age of 5 or 6 or 7 or even earlier. And as we've alluded to earlier, certainly brain injury precipitates notable difficulty and increasing difficulty in children at any age in managing complex tasks. Let's go next. The key question here is, in my opinion, is for all of us, is how does a school system, let's say your school system or school or community agency, or I would even include medical providers, how do we all work? And what approach do we actually use in facilitating a successful reentry or reintegration of a student into the school setting after a brain injury? The literature is replete with the idea that schools cannot do it. One teacher, a special ed teacher, or a regular education teacher, or a counselor, or a school psychologist, or an administrator cannot do it alone in a vacuum. And I would bring in the community agency, the medical provider, a parent or parents, or any others cannot facilitate, well, I think across any setting, but we're talking about school settings at the moment. It takes a substantial group effort where there is a respect for each individual discipline, for the information that any of us can bring to the table, a capacity for problem solving and patient application of good clinical practice and good teaching and good program design. All of that, I could go on and on about that. When multidisciplinary teams or groups come together with good intentions, with the right focus on the child focused, then that's when, in my opinion, the most successful reintegration of students with brain injuries or any other kind of situation occurs. But particularly in the case of a child with a brain injury, where any number of things can be variable, and a child's presentation may be appear to be one way for a few months and then change a little bit because of the latent issues I've noted. But it's very important that these groups are well focused, and we're looking at not just ideas off the top of one's head, but looking at truly potentially effective evidence-based interventions. And each discipline certainly has the capacity to bring what they understand to be evidence-based interventions to the table to address academic and behavioral skills and the acquisition or reacquisition of basic skills, which is going to be very essential in many cases. And we look at a wide range of approaches, adapting the environment, providing whatever aids and strategies are necessary, and then in many cases, applying the applicable specialized instruction and accommodations, either through general education, Section 504 for special education services. Next. Now, what do we need to do in order to come up with such effective planning and intervention? We may need to collect some additional and different kinds of information. We certainly should have good initial medical information available, and ideally neuropsychological evaluation, or eventually when the child comes back to school, you may have a school psychologist like myself who has the traumatic brain injury provider training and credential. We're certainly not neuropsychologists, but we're school psychologists with that additional training that will do various sorts of assessments looking at how a child's currently functioning and what the sorts of things that we need to do. But aside from that, in my opinion, there's more information on a day-to-day functional level that can be collected. Now, some of you, particularly educators, but maybe other providers as well, are familiar with functional behavioral assessments, where you collect a wide range of data. Some of it may be standardized, but a lot of it is anecdotal, observational, and you're looking at specifically what seems to be causing or precipitating a child's relative behavior. Well, there are some traumatic brain injury checklists that are comprehensive and that, in my opinion, are just remarkable, that can be used to collect day-to-day data, and parts and pieces of them could even be used for progress monitoring purposes, which we'll talk about again in a few minutes. I have two documents. One I think is on the next slide, but the Center for Brain Research and Training, CYBERT.org. That is a great resource. I would write that down. I will have it in the, eventually when I send the reference and resources list to Lauren, it'll be included in that. But that is a great, along with the Brain Injury Association of America and North Carolina chapter has great resources. That site has great resources. And there's another checklist that's dated, but is still very good. And that's at the Virginia Department of Education. It's the Virginia Department of Education Traumatic Brain Injury checklist. And you could probably Google that and find that. Go to the next slide, please. Let's see. Now, I won't go through all of this. Well, I'll look at a little bit of it, but there's an old saying, kind of colloquial, that some of you may have heard before, particularly if you're teachers or other educators, and even parents may have heard this or even said this. Good teaching is good teaching. And just because the child has a brain injury, and I've said this many times about other disabilities, just because a child has any type of identified disability, and in this case, we're focused on traumatic brain injury, that does not mean that all of us involved in education should think or gravitate to only specialized instruction, or think that we have to do special things. We still have to use good, sound instructional practice and design our curriculum and instruction in a sound fashion, in a general way. So I would argue that all of these things are especially important for children who've been injured, but they're also very important for every single child sitting in that classroom. And a teacher who approaches it this way will have great success, in my opinion, for the wide range and the diverse classroom groups that he or she address. I'm going to brag a little bit. I happen to live with a master teacher who's now an administrator, but she was a great teacher and a great director of curriculum and instruction, because she believed that she could teach any class or any child in her classroom. She made no assumptions about who was very weak, or no assumptions about who was very bright at the beginning. She was focused on trying to help every child learn as much as they possibly could. And she took that practice from her teaching into her curriculum and instructional work, and now as the administrator for a significant preschool assessment and intervention program. So thank you for allowing me. Well, you didn't have much choice, you had to listen to it. But I have learned a great deal about, I guess the bottom line is I've learned more from her about teaching and curriculum and instruction than I have from any course I've taken in education or from any other experience I've had. So I've had that fortune, and I've come to the conclusion again that good teaching is good teaching. And that matters to every child, whether they have difficulties or not. It matters more to those children and adolescents who do have learning difficulties or do have a specific injury like a brain injury. Next. Okay, now, I want to begin to discuss, and I must admit, it looks like I'm beginning to run out of time, so I'll talk a little faster. There are some teaching methodology embedded in the literature that has been researched with children with brain injuries. There does not appear to be as much as I would have hoped. And I can't say that I did an exhaustive review of the literature, but I did look at a good bit of it. But there are several specific methodologies that there is notable literature support for. I certainly, in this limited amount of time, cannot discuss those at any great length. I can identify them for you. One is called the direct instruction model, which is essentially an approach to breaking academic tasks down into the smallest units possible. And that's certainly what a lot of our brain injured children need at first, particularly if they're relearning things that they may have lost. And another is called the precision teaching, precision teaching approaches, which are similar to the direct instructional model. So I leave those. We'll go to the next slide, which we'll talk a little bit more about these. But if you're interested, please Google these or go to whatever sort of search engine that you have available that can discuss these things in greater length. I certainly, as I mentioned at the beginning of this webinar, I certainly am not pretending to be able to train on or teach any specific thing. We're more about bringing a few things to the level of awareness. That's what I would consider this time together to be, is maybe increasing one's awareness, invoking some level of interest and motivation to pursue things further, and to give you maybe a basic platform from which to become increasingly able to design and implement accommodations and interventions. The direct instructional model is the fundamental process is broken down here. And again, I would consider this good teaching, good instructional, sound instructional approaches that need to be fine-tuned and tailored to the individual needs of kids at any age level with brain injuries. We can go next. Okay. And there are, here are the precision teaching. This is more of a rationale or I won't say philosophical, but it doesn't tell you necessarily what to do. It gives you the premise, like what is happening to the child is most important. That's what we need to be focusing on. And I'm going to talk a little bit more about that in a moment, but it's especially important for children with brain injuries. We have to address things that are observable, not things that we assume are occurring or not occurring, whether that is academic behavior or social behavior. Frequency. We have to be progress monitoring regularly and frequently, not now and then. And we have to be data driven in our instruction. So another term I could have thrown in here is data driven instruction. I would recommend any of you write that down, data driven instruction. In terms of skills, specific skill development, it's going to be essential to use data driven instruction for children with various sorts of injuries, brain injuries. I have borrowed liberally from 2 PowerPoints that I'm going to put into the resource package or packet, and I would encourage all of you to if you're interested in precision teaching and direct instructional models, to take a look at, because they've incorporated a lot of this information into their PowerPoints. Okay, next, please. Okay, there's a table that I have provided, and I think if you get if you access the whole PowerPoint, you'll probably be able to click through it. But if Lauren, if you'll go to the next slide, I think, yes. Now, Lauren, click down on your side. I won't call it button, whatever it is on the side, and see if you can scroll through. Yeah, no, not that. Can you scroll? Can you scroll on this slide right here? Is there a way to scroll through it? I tried to copy and paste that into my PowerPoint, and that little bit is the only part that came up. But let me describe this. This is a great figure because it shows the behavioral supports that can be used, and it makes suggestions about exactly what to do, and there's a reference beside each. Yes, it keeps going down. It doesn't show up when the slide comes up, but as you scroll down, you can see it. There we go. So that's not all on one slide, but when you scroll down the initial part of the slide, you can see all of it. So as you can see, this is a great resource, at least in my opinion it is. It gives you some real explicit, specific things that you can do, that a teacher can do, or that a team can use to develop a real clear plan for a child based on his or her immediate needs. So that's a great resource, and you'll have access to that within the packet of materials and references that will be provided and then you can access, I'm assuming, on the brain injury website. Now we're looking at executive function. And I've used the Roland PowerPoint. I've cited it obviously here. I've given a citation for having used it, but I decided there was no need to reinvent the wheel, because there, or his, or it might have been her. Yes, it was her. Her PowerPoint is just excellent when it comes to this particular aspect. So let's keep going. Lauren, next, please. Yes. First of all, this is the area where likely the most important interventions need to be designed and implemented upon reentry into school, because kids are going to have, most likely, almost any child of any late age level that comes in are going to have some issues with memory, with attention, with organizing, with planning, etc. So making sure that you as a teacher or you as part of a team plan for this is essential. So there are probably more slides related to executive functioning and how to address that in this webinar than practically anything else, any one area. So here are the components of an intervention plan for executive function. You've got to get as much information as you can about how the child is functioning. And it may take several weeks, maybe a month, to make observations, to collect information from parents, to get in for other information from providers. And you utilize that information and analyze it to delineate the areas you want to address, the problem areas. And you link the issues to executive function, individual executive functions, to the extent that you can, and that best describe the problems that a child may be exhibiting. And then you look at whether or not a child functions in the same way across settings, especially, or across domains, which means, are they having a lot of problems across every domain, like planning, organization, attention, etc., or is it more in how they organize things, or are they struggling with paying attention, which then affects everything else? Or do they have more problems in Ms. Smith's classroom than in Ms. White's classroom, etc.? And then you pick, like any other sort of intervention planning, you can't address every problem all at one time. So you pick the one or ones that seem to be most significantly interfering with the child at the time, and that will be the most beneficial and meaningful to the kid. Next. Now, have you ever thought about changing or modifying the classroom? You know, it may be some relatively simple things that an individual teacher can do or the school can do. But, you know, in my experience for many, many years working in a lot of schools and working in school systems, sometimes the most straightforward, simple modifications or adjustments can be the most charged or difficult ones to implement. I hope you're not in a school or school setting like that. And I'm not trying to sound too pessimistic, because the majority of the time people do what is in a child's best interest. But now and then, getting people to restructure their classroom a little bit, or adjust background noise, or take some very colorful but almost irrelevant pictures off the wall, or here's this more difficult to change the physical restrictions. Sometimes there is a little bit of money that might be involved, or a little bit more effort than usual to make physical modifications. Now, using list or visual reminders, that gets little to no resistance. Improving organizational structures in a classroom, that varies from teacher to teacher or from school to school as well. But as much can be done to facilitate a child's improved executive function by changing the environment as it can be, maybe more so than actually trying to teach the child new skills or help him or her relearn skills. So keep that in mind. Changing the environment can be a very important, essential aspect of any kind of intervention plan. Next, please. These are some common ideas for common strategies for organization. You can go to the next slide. We have more possible strategies. Next. That provides you additional sampling. And next. Now, why would we even consider cognitive flexibility? Just take a moment and reflect upon that. Why have I even mentioned that as something that we would want to visit or address with a child with a brain injury? Well, what is the key to problem solving, just as a general process? It's a capacity to be relatively flexible in our thinking and to consider several ideas simultaneously, and to often consider the perspective that either others are taking or the perspective that might be emerging in the environment you're in. In other words, problem solving can be a relatively complex process, even under typical or normal circumstances. But if your capacity to be flexible is limited or has become limited, then those who are working with you, working with the child, need to do everything that they can do to help a child become increasingly more flexible. And as I said from the very beginning, this is not a one and done intervention kind of process. You'll be in the long haul helping kids make progress in very, very small increments in terms of how to do any of these things. But flexibility, the executive functioning in general, as it improves, particularly as related to cognitive flexibility, will have, if that improves, it will have a notable impact on just about every other aspect of learning, in my opinion. Knowing what to do, where to do it, how to follow some sort of scheduling, and then you have to ask yourself, what is the most important to you as a teacher, parent, or student? Because you're going to have some situations where the child, especially early on, is going to struggle with okay, you told me to do it this way yesterday, and I did it, but now things are changing a little bit. The capacity to be flexible enough to change day to day, week to week, situation to situation. That's an additional aspect of cognitive flexibility. We have some additional strategies on the next slide. And the next slide. And let's go to the next slide. Yeah, self-monitoring. Think about that for yourself as an adult. Yeah, how difficult it is sometimes to monitor your own thinking and your own behavior and apply that to various situations. How you speak and behave in your family situation around people you're secure with and comfortable with, certainly for many people, if not most people, is going to be a little different, and sometimes a lot different than when you're at work, in your work setting around people that you're probably comfortable with, that you know fairly well, but you're still going to be a little guarded because you may feel, and rightfully so, that your work product or your work and how you work is going to be judged or evaluated. So what do? We monitor what we say, we monitor what we do, and that's very appropriate. It's very appropriate. And then, you may monitor what you say and do in other kinds of gatherings or social settings. Well, I would argue, I know for me, that sometimes that's difficult because I may just be going with the flow and enjoying myself across settings, and then it dawns on me, you can't say that, not yet, not here. Well, a brain injury to the frontal cortex, to the frontal lobes, where executive functioning is the part of the brain where all that takes place. Organizing, planning, monitoring, inhibiting, or exhibiting, all those processes occur. So just think how difficult it is for a child anyway. All of us from a young age, we get better and better at self-monitoring and checking ourselves. Young children are relatively disinhibited. Then they have a little stage where they're kind of reserved. And then in adolescence, they become disinhibited again. So if there's an injury along that developmental path somewhere along the line, then their capacity to modulate, it's almost like being able to, to fine tune whatever, a radio, or to regulate your temperature, self-regulation. So, having said all of that, part of what we are challenged with and need to do is to begin assisting children in their own self-monitoring and self-regulation. And again, that will be a slow process. You have to be explicit. You have to be very straightforward. And you also have to measure success in very small increments. Next. Now, I'm running out of time, so I'm going to go a little bit faster. The thing I'll say about cognitive scripting, think of metacognition, thinking about thinking. That's, we don't use that term very often, but, the capacity to self-regulate and do a lot of other things in terms of executive function is highly dependent upon our capacity to think about what we're doing or to think about what we are thinking about, which sounds a little strange, but that's basically a straightforward way to put it. thinking about thinking. So you have to reteach a lot of things to children who've had some form of injury. And these are ways that we can do that. So let's go to the next. We have to help children get reoriented to the learning process again. And here is a way that we can do that. We may more or less have to be very concrete and visual in the approaches that we take. Again, a lot of the things that we're talking about are also used with children having other kinds of learning struggles that have not had an identified or reported brain injury, but yet they are important. The distinction, in my opinion, between kids with other kinds of disabilities and kids with a brain injury is that we know that there is a brain-based reason for a lot of what we may be seeing, and we have to figure out not so much what the brain physiology is, but we have to know what we need to look at how a child is functioning and address really specific things related to that. And the more skilled some of your specialists are, the better able the teachers are going to be to make that jump from understanding how a child's functioning to designing and implementing interventions and accommodations. So here's a range of orientations, accommodations related to orientation issues. And the next slide shows accommodations for problem solving. And I'm sorry to be moving on, but I'm gonna have to do that. Next slide. And here, common sense guidelines in general. This, again, this is in my opinion, is good teaching. This just simply delineates and describes what good instruction as a process, as a practical matter can look like. Next. Now, I'm just going to allude to the next 4 or 5 slides. These are, the next slides are related to memory and learning, basic reading instruction, basic math instruction, and written language. I am not going to go through each one of them, but I will say this. Good specialized instruction across these areas is good specialized instruction for virtually any kid with a disability. There are several very key points I want to make before closing. One, if you're an educator in North Carolina, you should be increasingly familiar with the acronym MTSS, multi-tiered systems of support. Now, I've argued for many years when training on response to intervention and multi-tiered systems of support that every child, including kids already identified in the Exceptional Children's Program or Special Education Program, we should be working with these kids, all of them, every kid in the building nearly, and from a multi-tiered systems of support perspective. This is particularly true utilizing the strategies within MTSS, which is designing and implementing a level of instruction that's necessary to assist an individual child. And the other concept is monitoring that child's progress on a very regular basis. I would argue with a brain injured child, they should be getting little teeny measures of performance at least 3 or 4 times a week, because we need to be measuring how are they progressing over an extended period of time. And if you're attempting an intervention and it doesn't seem to be working after a week or two, or whatever time you decide to try it, then you need to know if it's working or not. And if it's not working the way you would expect it to work, then you need to take a look at your data again, and or you need to fine tune your intervention. That's important for any child, but it is really important for children with brain injuries. And second, here's another thing you can Google that's not talked about nearly as much, at least in our state and in our schools, as it is, as MTSS is, but universal design for learning. Using that general and approach that has very specific methodologies to address the needs of children with brain injuries, I think is essential. So in the elements of MTSS and the key elements of universal design for learning, in my opinion, that's foundational to developing evidence-based practices and interventions and accommodations for young children, elementary children, and children at the middle and secondary levels. So I'll end with that part, and I do want to read what you can go to the very last slide, Lauren, my final thoughts. I'll just go ahead and read that real quick, my final thoughts. Children across the developmental spectrum who have experienced traumatic brain injury very often need substantial and ongoing support from educators, community providers, as well as family members. How well we plan for, design, and implement evidence-based interventions and accommodations most likely will have a great impact upon how well they are able to recover towards a more normal developmental trajectory and make as much academic progress as possible during their educational history. Many thanks for your participation and indulging my presentation. I sincerely wish I had a whole day, because we could actually do a good workshop on all of this, and I could have gone into more detail. On the other hand, I think this association's approach to webinars does a great service to our state and others in providing information and hopefully motivating folks who participate to do their own research, their own study, and to increase their own skills and expectations for delivering increasingly more effective services to children and adolescents with brain injury. So thank you so very much.
Thank you so much. There was so much great information in that presentation that I really look forward to. Hopefully everyone out there was able to get something. I really enjoyed a lot of the common sense strategies, or what you said was kind of the basic teaching strategies, I think could also be implemented in parents for, how they're interacting with their children, providing choices and, asking questions and just sort of framing how they interact with them. So I think that could be approached from a lot of different angles. So one of the questions that we have is, you indicated that a team approach is really the best way to interact with someone that is living with a brain injury, a child with a brain injury. Do you have any resources specifically on how we can kind of educate all of those team members, or is there like a point person that can be assigned, or that you see as who can kind of instigate that team building? Because I find that people will be like, well, that's someone else's problem. And so then no one takes charge. And then you don't necessarily get that team. You get one person working as hard as they can to support this child. So is there any additional strategies you can have for building that team and making sure that everyone is educated to be able to support?
Well, that's a great question, and I can speak to what I know occurs in most school systems, most schools in North Carolina. Um, each school has an intervention team. They could be called a lot of different things. Within the last several years, those teams have often been referred to as multi-tiered systems of support teams. Other schools might call them student assistance teams or student support teams. That's the team that precedes a referral to special education. And often that's where, that's the team that is utilized when children are struggling and parents may come in and ask for assistance, or teachers may be seeking assistance in supporting a student. However, in many, if not most cases of traumatic brain injury, when a parent provides information, let's say it could be to the school counselor, it could be to the principal, or they could possibly even go straight to special education director at the central office level. Often that invokes a referral to special education. And in that case, it is the IEP team, the individual education plan team, that begins looking at the available information upon referral, meets as a group to determine what further evaluations may be needed. And then, assuming that a child's found eligible for specialized instruction or special education through the category of traumatic brain injury, then a comprehensive individual education plan is developed. And that IEP team can be made up of as many people as appear necessary to develop that plan. It's going to always involve the parent, or at least the parent's going to be very invited multiple times. And in the case of traumatic brain injury, I've never been to one where the parent wasn't showing up or coming. Other kinds of categories of eligibility, now and then parents defer coming. But you have the regular education teacher, a special education teacher, often the school psychologist, speech pathologist, possibly occupational therapist, physical therapist, a wide range of disciplines that might be working with a child. And given the nature of the TBI, the team is likely to be pretty large in discussing and planning. Now, with the MTSS team, the multi-tiered systems of support team, that can be relatively small, but it also depends on the nature of the concerns. I would have to say, based on my observations, that it's a very flexible thing in terms of team, who comes to the meetings, or joins these teams. You know, my basic point of view is that the more information that can be provided to those teams is the key element. If it requires a wide range of disciplines, that's fine. If it requires fewer people utilizing information that has been gathered from the community, that's fine too. the important thing is to involve as many disciplines and as many people as appear necessary at the beginning. And then that could change over time. Fewer people or more people might be involved in those meetings. The key is gathering the kinds of information that can be translated in some form of action, whether it means further evaluation or whether it means being able to begin to design and implement interventions. That's the key. I think, again, just like the idea of cognitive flexibility that we talked about briefly with a child who's been injured, wanting to develop that, those teams need to approach things from a very flexible student or child-centered perspective. And that allows us to be able to bring in whoever we need. And if a school itself puts limitations on that, or if a parent puts limitations on that, or if a community provider says, well, I'm not getting paid to come show up, so I'm not going to do that, I'm only going to provide reports. Those are the kinds of unnecessary limitations, in my opinion. We all need to be very open-minded and very student-centered. I mean, I'm being very idealistic here, but I'm at a point in my career, in my life, where I could promote very idealistic ideas because I know those are ultimately what's going to be the most productive and effective. We need not only to be pragmatic, but we also need to be very open in the way we approach things. I know that's a long-winded answer. I hope it helps. But again, getting back, the key people are going to be the school counselor, the school administrator. If there's a school psychologist that's assigned to a building and there all the time or several days a week, that would be a key person too, because they probably are going to, I'm biased because I am one, but that individual is going to do more to get things rolling than probably anybody else, because they're going to understand the nature of brain injury and other disabilities more than the others. So they're more likely to take quick action to get the ball rolling.
Yeah, I think that's a great point. And I'm going to add in the chat a training resource from the NC School Psychology website. They do have a TBI online curriculum, so that might be something for other individuals to get involved in. We did have a comment mentioning about practical ways to meet needs in the classroom, just because you don't want people to feel like more work is just put on them. So it's good that you framed a lot of different opportunities and different people that could be involved in that process. My last question, I know we're over time, but I really am curious. You mentioned towards the end about data collecting and how important that is for teachers to be able to see kind of the changes that a student might go through and see if they're improving, if they're not, what changes need to be involved. Are there specific resources out there that people can, print off to help collect that data? Or is that something that either the Brain Injury Association can help partner with others to be able to develop?
Well, first of all, what I can do, and I'll make a note, and maybe you could remind me through an email, is I can delineate that kind of information in the resources, or references. But I can, off the top of my head, I can give you several. One is studentprogressmonitoring.org. I think it's .org. Or another thing you can do is just Google student progress monitoring, and that will give you tons of things. Another website is RTI Network, and that's either .org or .com. Another is What Works Clearinghouse. And you may have to just Google that. I think it's whatworksclearinghouse.gov. I think that's .gov. And, one of the things that I did from the very beginning of preparing for this is I Googled instructional strategies or teaching strategies for children experiencing traumatic brain injury. And then the same for adolescents experiencing brain injury. And also went into my, I still have access to some academic search engines. So I went into an academic search engine and just wrote in something similar, and got a bunch of research studies that I have read and alluded to. That's going to be in the group of resources if anybody wants to go to that extent. But the real important thing to do, in my opinion, if you're on a planning team or whether you're a teacher wanting to design or find things yourself, be sure that you're utilizing evidence-based practices. That means essentially there is some level of research support for the practice that you're going to implement with the targeted group of children, in this case, children with traumatic brain injuries. But I would say that, again, good specialized instruction, if the main thing about data collection is you want to know what is the current skill level, whatever the subject matter is, of the child that has re-entered school. Knowing that, and then designing really basic interventions that target that, and then monitoring that child's progress closely over time. That's the approach that that I would strongly recommend, virtually for any child, but particularly these children.
Excellent. Yeah, sorry, go ahead.
I was going to say, because while some teachers may want to make assumptions about how well a child is doing or not, this is not the day and age to make assumptions. We have to be data driven in the way we approach things, in my opinion. And even if you don't buy into that as a general idea for general education students, children with a traumatic brain injury, we're talking about a child that needs a lot of support potentially over an extended period of time. And we need to know what we know. And we need to know what that child knows or doesn't know over time, as best we can assess it. And we can't assess it unless we assess it. And an EOG, end of grade test, or a benchmark is, I'm just going to say it, is essentially worthless for children with these, I'd say any special ed kid, in my opinion, but that's could be controversial. It shouldn't be controversial to say, though, that progress monitoring with using end of grade tests or only benchmarks is useless. That should be a given. If it were me, or if it were the person I was alluding to earlier in the presentation, she would be doing it every day. She wouldn't be spending an hour, a half hour assessing. She'd be doing a minute here, 2 or 3 minutes there. She'd find a way to know how that child is doing socially, emotionally, and academically. If they came back into her classroom as a child who had just experienced a brain injury. People have to have a heart, but they also have to be pragmatic and professional in their approach to educating children.
Absolutely. And I put some of those links in the chat here, some of the resources that Joe mentioned. I think that's it. I'm so thankful for all of the resources and information you gave today. I think it's really important because when we're talking about the executive functioning challenges in children with a brain injury, that's when you typically see it spilling over into behavioral challenges. I tend to see behavioral challenges, the underlying root is oftentimes that executive functioning, overstimulation, so I think that these resources and strategies are going to be really helpful for not only executive functioning, but all of the other functions that executive function spills into, you know what I mean? So I'm really thankful for everyone here today. Please be sure to fill out the survey. You can also get your specific certificate through our website. I'll be putting this presentation, the recording, any other references and resources that we compile on our website within the week. So be sure to check back there, and you can also share it with other individuals that might be interested. And I hope to see you register for our next webinar on May 24th, focusing on preschool age injury and what that looks like in terms of brain injury and development. So thank you so much, Dr. Bunch, and I really appreciate it. We're getting a lot of positive comments in the chat as well. So I look forward to talking with you soon and collaborating with you in the future.
Great. Thank you so very much. And thank you to all of you for participating and asking really salient questions.
Excellent. Thank you so much. Have a wonderful day, everyone.